Coast region, Dr. Jocelyn Asibe. So, Dr. Asibe, if you're with us, you can unmute and give us your beautiful welcome address. Thank you.
Thank you so much, Nanama. Good afternoon, everyone, and greetings from Koforidua and the entire Eastern region. I hope I'm being heard.
Loud and clear.
Can you please hear me? Yes, thank you so much. I am and the entire Eastern region team, we are very excited for the opportunity to host the Jaundice Awareness Month. We are so great. I want to say a big thank you to the National Secretariat. I mean, without their support, we couldn't have been the host. I am truly grateful, and greetings to everyone. Thanks for all the work wherever we are doing to support our newborns, and especially this month, the Yellow Month. The theme, from awareness to action, promoting timely diagnosis and treatment for all jaundice newborns across Ghana, couldn't have come at a better time. This is the best time for it. There's been a lot of awareness all over Pediatric Society, and all newborn champions are doing excellently well, but it's time for action. It is, I mean, with all the good work that we do, we still have a lot more to do. We are still having newborns with severe jaundice and the associated complication, which is not what we want at all. So this is a call to action for all of us to diagnose them on time and then put in the appropriate treatments. I believe all of us here will get the message at the end. We'll learn a lot, and then we'll go out there to be advocates for our newborns, especially in the timely diagnosis of jaundice and its treatment. So with this message, I welcome you all. Greetings once again from the Eastern region, and thanks so much for the opportunity. Over to you, Nanama. Thank you.
Thank you so much, Madam Chair. Thank you so much, Eastern Region, for the beautiful work in launching us into today's program. So I'd like to welcome the chairman to give his opening address and to introduce this chairperson. The profile is long. It will take me probably a year to finish going through his profile. But to simplify it, this man is an associate professor at the Department of Epidemiology and Disease Control and Family and Population at the University of Ghana School of Public Health. The most important thing for me in everything I see is that he has a postgraduate diploma in pediatrics from the Royal College of Pediatrics, Ireland. His current position, in addition to being at University of Ghana School of Public Health, is also holding the Associate Professor, Clinical Epidemiology and Public Health from the Faculty of Epidemiology and Public Health from London School of Hygiene and Tropical Medicine. People, I don't know who else would have held this chair better than the man himself, Professor Alexander Menu, and I'd ask that you welcome him with a resounding round of applause, a virtual one at that. Prof, the floor is yours.
Thank you very much. It's a real pleasure to be here. When you introduce me like that, you confuse me. But it's a real pleasure to be among colleagues and to talk about such an important issue like neonatal jaundice. For me, I would say a big thank you to the society for this initiative, and also for all the efforts that would be going into this month to make sure that we save lives of babies. The baby is always on my heart, and I always like to hear things being done for newborn babies. But just to put jaundice in perspective, an estimate shows that in Africa, about 66 or 67 out of every 1,000 live births are babies that would suffer severe jaundice. This is not just jaundice, but severe jaundice. Some work that has been done in Ghana, in Kumasi, in La Paz, and in other areas have shown that the prevalence of jaundice is quite high. And some of these progress into severe jaundice without access to appropriate care. In fact, the prevalences that have been reported in those studies were between 48% and 95%. And if we have these rates, knowing what the complications of jaundice can be, one is worried about not only their survival, but beyond survival, babies must thrive and reach their optimum potential. And so if we have these insults to them very early in life, especially when the brain has the highest neuroplasticity, one is always worried about what generation are we expecting in the future. I've also tried to look at the title or the theme for this year's celebration. And the theme is talking about early diagnosis. And I think that this would have several components. And I know that our colleagues are going to be educating us on some of the things that we need to be thinking about. But from where I sit, when I hear early diagnosis, the first thing I ask myself is, will the mother even be able to know whether the child has jaundice that needs appropriate care? And I'm asking this because I think that sometimes we relegate some of these, or we move some of these responsibilities to mothers. The jaundice that we are always worried about are those that are occurring on the first day. And with 88% of babies being born in health facilities in Ghana, it means that there is the possibility that we can see many of these jaundice cases and be able to do something about. However, we discharge mothers too early after the birth that sometimes we don't have the opportunity to see. So it means that the responsibility has been moved to mothers. And when mothers have to make this diagnosis and come back to the hospital, we know the challenges with that. There is also the challenge about referral systems, that we are in one facility and we want to move the baby to a facility where they will get the appropriate care. But what it takes to take the baby there is always a challenge. I like the fact that we have moved forward with neonatal jaundice, and I like the fact that we have devoted a whole month to talk about neonatal jaundice. But I don't think that we should only be talking about these on professional platforms like these. And we don't need to organize floats necessarily to be able to spread the message. We have opportunities in our church communities, in the markets we go to, in our children's PTA meetings, and various fora for us to be able to spread the message. The worst case scenario is for you to say that I'm coming to seek care. And if you seek care and you don't, the doctors tell you that everything is fine, then you can go home. In previous work that we have done in Ghana, looking at jaundice care in Ghana, there is also a disparity and an inequity in the distribution of supplies and what it takes to make an early diagnosis for jaundice. So if you look at phototherapy, when we did 185 facilities in Ghana, we realized that in the north, even though we would have 77% facilities that we assessed said they have phototherapy equipment, some improvised, some proper ones, we realized that in the northern sector, 88% of facilities said they had. But when we come to the southern sector, 80%, but in the middle belt in around Ashanti, Brong, Bono East, and Bono regions, we only have 68%. The converse, however, is true when we come to looking at whether they are able to do serum bilirubin and exchange transfusion. And you would see that for serum bilirubin, the southern sector has 84%, the middle belt has 68%, and the northern sector has only 54%. And for exchange transfusion services, it's even worse. So basically what I want to say is that there is a lot of work to do, but it starts with a conscious investment of time and resources. And I think that for those of us that are on this platform, we have a unique opportunity to change history, not only for Ghana, but for the children who would be the future of this country. And just to cut this long story that I've said short, I want to say once again that I'm really privileged to be among colleagues to have this special launch of the Ghana Neonatal Jaundice Awareness Month. And on this note, with the powers vested in me, I will declare the Jaundice Awareness Month for Ghana duly launched. It's yellow. Thank you.
Thank you. Indeed, it is yellow. Thank you so much, Prof. Chairperson, for the occasion. And Prof, I'd like to take a few words from what he said, highlighting the fact that we're discharging the mothers too early, and then the onus falls on them to detect what if they are not seeing. Also, our referral system is a problem. But the most important thing is that we have to consciously invest our time and resources and be an advocate for neonatal jaundice every day, not just in May. And so we're moving on. Thank you once again, Prof, for that wonderful speech. We're going to take a word from our National Executive Council, that's for Pediatric Society of Ghana. And to do this is the Vice President himself, Dr. Med Emmanuel Opon. Doc, over to you.
Thank you, Nanama. I hope I can be heard.
Loud and clear. You can be seen as well.
Wonderful. It's an honor to welcome all of us to the official launch. Prof has said a lot and has taken the wind out of my sail. Incidentally, I happen to be somewhere in the eastern region, in a village, and I had one of the kids run around. And one of the thoughts that came to me was, if this child who was born in this village had jaundice, how would the mother be able to access the care? In fact, even be able to detect that this child has jaundice. And it's only appropriate and apt that I'm in the eastern region at this time that we are launching this month-long awareness campaign. Our theme this year is from awareness to action, promoting timely diagnosis and treatment for all jaundice newborns across Ghana. And I know my president, Dr. Hilda Boy, will be very excited about what is going to happen in the course of the month. Greetings from her. This theme reflects a national call to move beyond simply knowing about jaundice to taking bold and coordinated steps in the diagnosis and treatment of jaundice in the newborns, especially in underserved areas like I find myself. This theme is a rallying call to each and every one of us as pediatricians, as midwives, nurses, health advocates, and even non-healthcare workers. We are on the front lines of the fight to reduce complications associated with neonatal jaundice. In Ghana, we estimate that about 60% of all babies will develop jaundice at some point in their early life. And unfortunately, still a significant number of them will go on to develop complications that are 100% preventable if diagnosis and appropriate treatment is instituted. We have the knowledge. I see over 400 people on this call. That means we have the network. And here we have the voice to change the story. Too many families remain unaware of the signs of newborn jaundice. Too many health facilities lack the tools for early detection of newborn jaundice. And even when they do, they lack the facilities and resources to institute appropriate treatment. That must change. That must certainly change. It's a preventable tragedy. And we as members of this society, we are positioned in a very unique way to address this challenge. No child should ever suffer from jaundice and its complications. And through this month-long campaign, The society will work with all stakeholders at all levels to equip healthcare workers, to raise public awareness. As the chairperson was speaking, let's take it beyond the corridors of the hospitals and take it to the marketplaces, to the churches, to the streets. Let everyone, no matter where they are, whether in the rural setting or in the urban setting, know about newborn jaundice and know about what to do and have what it takes to address it. I urge all of us in this society to be involved, directly involved in this year's Yellow Month. Not just coming on WhatsApp to look at the pictures or reading or looking at the videos as people embark on various activities. Be involved. Let's see you in a picture somewhere. Let's see you in a video somewhere. Let's see you advocating for phototherapy, for all the basic resources that we need to make a difference. And I see a lot of my senior colleagues here. It's time to mentor some of our junior colleagues, even in our hospitals, so that they will take up this charge. They will take up this charge and will make a headway. Let us light every corner of the country with the color yellow and make sure that this becomes our most impactful year when it comes to addressing issues of newborn jaundice. Together, we can do this. Together, we can make this Yellow Month the best yet. And together, we can move from awareness to action, and we can save many lives and families. So I entreat all of us, let's enjoy this short event, and it should catalyze us to take bold action even as we go through the month of Yellow Month. Thank you, and over from me.
Thank you very much, Dr. Manuel Pong, for that charge. Indeed, it is a preventable tragedy. And like you're saying, we need to light every corner we find ourselves with the color yellow in this month of May. Thank you, Dr. Pong. Moving on, we will take your keynote address from our mother group, GMA. The president is here with us, Dr. Frank Serbo. If you can hear me, it's time to hear from you. Is Dr. Frank Serbo with us? Okay, all right. I think we will pass that on. Should he join us at any point, we may get him to give us his keynote address. So moving on then, we will be delving right into the meat of this launch. We are saying that we're moving from creating awareness to action. We're promoting timely diagnosis and treatment for all jaundice newborns across Ghana. The question is, do you know how to diagnose it? And when you do you know where to send that child for the appropriate treatment? If you don't, just make sure you get some relaxing seat, take a pen and a paper, ready to take notes, because our panelists are ready for us. Well-geared, well-seasoned people who are going to take us through these topics. So our first speaker is in the person of Dr. Nana Rekugrobe. She's going to be taking us through diagnosing it, knowing the medical courses, and how to manage it. If you see her profile, you know that we couldn't have chosen any better person to take us through this. So Dr. Nana Rekugrobe works at the Konfanoche Teaching Hospital. She is with the Mother and Baby Unit there. She's also a lecturer for the Department of Pediatrics and Child Health, School of Medicine and Dentistry at KNUST. She's a pediatrician neonatologist, and her many publications have centered around children and making sure that she's making impact and making a change. And so people, please take out any wax that is in your ear, anything that's going to impede you from hearing clearly this afternoon or this evening, as we welcome Dr. Rekugrobe to take us through medical courses and management. Doc, the floor is yours.
Thank you so much, Nanama. I hope you can all hear me.
Yes, please.
All right, okay. Pardon me, I don't think I'll use the video, just to be safe. So, hello everyone. I am going to be taking you briefly through medical causes and management of neonatal jaundice. So this will be, okay. You can all see it, right? Nana,
Yes.
are we good? Okay,
Yes,
all
we're
right.
good.
So this would be the outline. I'm going to delve right into it. So by way of definition, neonatal jaundice is the clinical manifestation of high levels of bilirubin in the blood, otherwise known as neonatal hyperbilirubinemia. And typically the baby would present with yellowing of the eyes, skin, and then the mucosal membranes. You all agree with me that neonatal jaundice is probably one of the top causes of admissions and readmissions in the first month of life. The study done at Cath in 2020 revealed that the prevalence of severe neonatal jaundice was 24.4%, meaning that for every 4 babies, one of them would end up with severe jaundice presenting for admission. So there are 2 categories of neonatal hyperbilirubinemia. You have your unconjugated hyperbilirubinemia and then the conjugated hyperbilirubinemia. For the purposes of this brief presentation, it's going to focus on the unconjugated hyperbilirubinemia. Again, in most neonates, more than 50%, in fact, more than 60 to 70% who come with clinical jaundice, it would be as a result of unconjugated hyperbilirubinemia. So that has 2 types. You have the pathologic and physiologic types. So what is the big issue regarding unconjugated hyperbilirubinemia? We're all concerned because unconjugated bilirubin is lipid soluble. So the concern is that then it can bind to the fatty tissue of the brain, and failure to promptly detect it and then initiate quick treatment could result in brain damage and then associated neurological sequelae. You could also end up with deafness, mental retardation, and then cerebral palsy. Cerebral palsy happens to be the only neonatal jaundice happens to be the only preventable cause of cerebral palsy. So it's rather a shame when a baby develops CP as a result of undetected neonatal jaundice. So based on the mechanisms of bilirubin accumulation or elevation, the etiology of unconjugated hyperbilirubinemia can be divided into 3 subgroups. You can have increased bilirubin production, decreased bilirubin clearance, and then increased enterohepatic circulation, among others. So with regards to increased bilirubin production, the newborn comes out typically with a hemoglobin level between, say, 14 and sometimes as high as 20, 21. And this results in the high red blood cell mass, which when broken down leads to a high bilirubin load. In the same vein, they have a shortened red blood cell lifespan as well. So the more premature the baby is, the shorter the lifespan. So with this rapid turnover, because breakdown of hemoglobin or red blood cells lead to bilirubin, they end up with high loads of bilirubin in the system. On the other hand, however, the liver is not mature enough to handle this huge load of bilirubin. It's been found that the UGT enzyme, which is the main enzyme responsible for conjugating the bilirubin, converting it from lipid soluble to water soluble, is just about 1% of adult levels around the time of birth. So that gives you an idea of how much the newborn liver struggles to conjugate and get rid of the bilirubin. Then we have what we call increased enterohepatic circulation. This is as a result of the beta-glucuronidase they have in their gut. Now, they tend to have the beta-glucuronidase in their gut because when the fetus is in utero, its function, the function of the beta-glucuronidase is basically to deconjugate the little bilirubin is conjugated so it can pass through the placenta for the mother to conjugate it. Unfortunately, because the beta-glucuronidase persists for a while, even after the newborn has come out, it still continues with the process of deconjugation. And this tends to happen when there's reduced gut motility. So you find that out that in mothers who do not initiate breastfeeding early, who are struggling with lactation, like first-time mothers or mothers who had a cesarean section and she's still struggling with the pain, or basically those mothers who are very ill after delivery. Their babies will end up with increased enterohepatic circulation since there's delayed establishment of lactation. So that's what happens with physiologic jaundice. The baby is fine, has no underlying medical conditions, but naturally, physiologically, will go through all these mechanisms, resulting in the baby becoming jaundiced. Oh, excuse me, my thing seems to have frozen. All right, so now we come to pathologic jaundice. Pathologic jaundice can be caused by exaggeration of the mechanisms that I've explained in physiologic jaundice, or by a certain underlying disease process. It is vital that you try to determine what could be causing the jaundice, as this could guide in management. If the underlying cause is due to hemolysis, then you probably have to be more aggressive in your management. Then it also guides you in your counseling of the parents, because most times if the mother has a jaundiced baby, the chances are that the next baby could also be jaundiced, especially if the underlying cause is due to, let's say, hemolysis or either be it immune or non-immune hemolysis. So subsequent pregnancies will be affected depending on what you tell the mother. So again, looking at it from the perspective of increased bilirubin production, decreased bilirubin clearance, and increased enterohepatic circulation, when you take the increased bilirubin production, the most common cause is as a result of hemolysis. So you have your immune-mediated hemolysis, the commonest causes being rhesus incompatibility and then ABO. With ABO incompatibility, the mother has to have the O blood type, and then the baby has to be either AB or AB. Then with the rhesus incompatibility, the mother has to be rhesus negative, and then the baby has to be rhesus positive. These are usually the two most common causes of hemolysis or immune-mediated hemolysis in our setting here. And with the introduction of the rhesus D immunoglobulin, that is for the mothers who can afford it, it has reduced the severity of the rhesus incompatibility. Then non-immune mediated hemolysis, so like RBC enzyme defects like G6PD deficiency, we all know that that is fairly common in our setting here. And even though it's X-linked and you find it more in boys, we're getting more and more girls also manifesting it as well. Then RBC membrane defects like hereditary spherocytosis, elliptocytosis. Unfortunately, to be honest, I'm not sure whether we just don't have the means to identify it here, or the private labs can do it, but because of cost, we are not exactly employing those methods. Then birth injuries, cephal hematoma, subgaleal hemorrhage, these results in collection of blood. And for these to resolve, that means that once the blood is breaking down, you're having more bilirubin forming. Sepsis, especially UTI, urinary tract infection. So especially for those who tend to have prolonged jaundice, it's been found that E. coli and Klebsiella, we've seen quite a bit of it, especially for Klebsiella on our units causing prolonged jaundice. You do the urine culture and then you isolate Klebsiella. But it's also been found that some bacteria causing the sepsis can cause oxidant damage to the red blood cells, thereby resulting in the breakdown of the red blood cells, and then you get bilirubin being released. Then polycythemia. Polycythemia is when the hematocrit is more than 65, 70%. So definitely once the excess RBCs break down, you have more bilirubin forming. And you typically see it in infants of diabetic mothers, babies with intrauterine growth restriction as well. So now we come to decreased clearance. So you have babies who have inherited defects. So these defects could either be qualitative or quantitative in nature. So it affects the gene that encodes the main enzyme responsible for conjugation of bilirubin. So Gilbert syndrome, but you hardly see Gilbert syndrome in the neonatal period. But when you take decreased bilirubin conjugation, you typically see that in Criglanaya. Criglanaya has two types. You have the type 1, which is autosomal recessive, and in type 1, there's complete absence of the UGT enzyme. So they are the ones who will end up with bilirubin encephalopathy regardless of what you do. And in the future, in fact, very near future, they are the ones who would require a liver transplant. Otherwise, they end up dying. But the type 2, they tend to have a bit of the UGT enzyme. So sometimes you have a baby who comes in, you've done phototherapy, 10 baby, by 10, 14 days, the jaundice is still not going. You've done all the investigations, they've all come out negative. And because it's difficult for us to test for Criglanaya here, sometimes you do a trial of Phenobab. Phenobab helps to stimulate the liver enzymes, and within a week, the jaundice has completely cleared. So as opposed to physiologic jaundice, where the levels of the UGT enzymes are low, just because it's a newborn, with regards to pathologic jaundice, the levels are low and are likely to remain low for life, unless, depending on which type the syndromes you're talking about. This takes us to the last one, which is increased enterohepatic circulation, plus some miscellaneous causes. So the first one is the suboptimal intake hyperbilirubinemia. That's a new name that the American Academy of Pediatricians have come up with for what we know as breastfeeding jaundice. So again, for mothers who are struggling to breastfeed or to establish lactation, it could result in dehydration, it could result in caloric deprivation, and then in some cases, they even say that the baby could end up with hypernatremia. And once there's very little enteral intake, that means that there's very little gut motility, and that allows for the bilirubin to be reabsorbed back and converted to the conjugated form. So then once it's conjugated, it has to be taken back to the liver for conjugation, hence the enterohepatic cycle. Then you have breast milk jaundice, or breast milk jaundice syndrome, as they are now calling it. With breast milk jaundice syndrome, there are quite a number of theories, but the most popular one is the fact that some mothers have the beta-glucuronidase in their breast milk. So whereas breastfeeding jaundice tends to happen in the first week of life, the early days of the first week after birth, breast milk jaundice tends to happen in the second week of life when lactation has been fully established. So because the mother has the beta-glucuronidase in the breast milk, the more the baby breastfeeds, the more beta-glucuronidase the baby gets. Then you have congenital hypothyroidism. So there's few mechanisms when it comes to congenital hypothyroidism. In fact, it's similar to infants of diabetic mothers. So the first one is the fact that because everything is slowed down, even gut motility is slowed down. There's also impaired hepatic uptake of the bilirubin. So if the liver is unable to take up the bilirubin to conjugate, then invariably it would end up accumulating in the blood. And then also there's reduced UGT enzyme activity. So these three tend to contribute to the buildup of bilirubin in the blood. Sulfur medications like ceftriaxone, sulfur medications like sulfamethoxazole, sulfadoxime, and then also ceftriaxone. So how they work is that they displace the bilirubin from the albumin binding sites. Albumin is responsible for transporting bilirubin to the liver for conjugation. So, one, if the drug is competing with the bilirubin for the sites, then that means that once the drug displaces it, then the bilirubin would be sort of free and moving about in the blood. And then once it accumulates, it can also deposit in the brain. Intestinal obstruction, a typical example would be duodenal atresia. So again, because there's some kind of obstruction, there's something blocking the movement of the intestinal contents, the beta-glucuronidase gets the chance to deconjugate whatever little bilirubin that the liver has managed to conjugate, resulting in increased enterohepatic circulation. Then I've already spoken about how the mechanism for infants of diabetic mothers. So when is jaundice pathologic? When it is noticeable within the first 24 to 48 hours of life. Some say 24 to 36 hours of life, 48, but just to err on the side of caution, I prefer to take it 24 to 48 hours of life. The assumption or the teaching is that because the breakdown is very rapid, that means that as soon as a baby comes out, it starts building up. So once you see it within the first 24 hours of life, there's cause for concern. Then when the rate of rise of the serum bilirubin is more than 85 micromole per liter per day. So most texts, because they use a milligram per deciliter, in a certain we tend to use a micromole per liter. That's why I've changed it. So if it's more than 85 micromole per liter per day or more than 8.5 micromole per liter per hour, then that's cause for concern. Now remember that jaundice or the manifestation of jaundice is cephalocaudal in progression. So it starts from the head and moves towards the feet. So if a baby comes and then the baby is jaundice all over, because as it's approaching the feet, then the levels are going up, then it's definitely pathological. Presence of a danger sign. So AAP prefers to call it neurotoxicity risk factors. So here we're looking at danger sign here could refer to fever, could refer to temperature instability, could refer to poor feeding, etc., etc. But the whole idea is that if you have a baby who has a danger sign or has, say, a fever or has sepsis, then you're worried that the body's reaction to the sepsis could lead to release of inflammatory cytokines, etc., etc. And these could end up compromising the integrity of the blood-brain barrier. So then that means that the blood-brain barrier could have leaks, could have gaps, and then it would be easier for the bilirubin to cross and then bind to the brain tissue. And of course, history of a previous sibling having had jaundice at birth. When the jaundice persists beyond 2 weeks in a term baby or 3 weeks in a preterm baby, then when the direct bilirubin concentration is more than 20% of the total bilirubin, then you're worried about your conjugated bilirubin. And I'm said conjugated hyperbilirubinemia. And I think the next speaker will be talking about that. So assessing the baby for jaundice. Baby should be assessed in natural daylight, okay? The light in the room can impact, can have an impact on how you see the baby. And like I mentioned earlier, progression is cephalocaudal in nature. You're looking for yellow eyes and skin. Check the white part of the eyes. Only if baby, you're able to get the baby to open the eyes. The more you try to get the baby to open the eyes, the more the baby will tightly close the eyes. You can blanch the skin on the bridge of the nose, the palms, or even on the chest, the trunk. If you're not sure, refer for a second opinion. Ask for a second. It is always better to err on the side of caution. Do not rely on visual inspection alone to estimate the bilirubin level in a baby with jaundice. So long as there's any hint of jaundice at all, you need to check it objectively, TCB or SBR. So now management. Basically, the approach is determined by the presence of certain factors. factors. So, and your toxicity factors, like I mentioned. So it could be, is there hemolysis? Is the mother's blood group O? Is there sepsis, temperature instability, even albumin levels? So if the albumin levels are less than 30, you're worried, because then, like I said, is the albumin that what transports the bilirubin to the liver for conjugation. So if the levels are low, that means that it can bind to very little at a time, leaving a lot of it roaming in the blood. Then the gestational age, and then our specific serum bilirubin. Always remember that when it comes to unconjugated hyperbilirubinemia, we do not deal with the baby's age in days. We are looking at the baby's age in hours. So it's always days plus hours, days plus hours. It makes a huge difference how you approach the baby depending on the age. Then encourage frequent exclusive breastfeeding. Okay, remember that if we remember metabolism of bilirubin, okay, at the end of the day, the conjugated bilirubin is converted to lumirubin, which can be excreted in the stool and the urine. Okay, now one way we used to check whether a baby is getting enough breast milk is the urine output. So the more the baby breastfeeds, it has a two-pronged approach. If the baby is breastfeeding very well, the baby will be passing more urine with the lumirubin in it. And then also, the more the baby breastfeeds, the lower the chances that there will be what? Enterohepatic circulation. For some reason, there's this practice where as soon as a baby comes with jaundice, you want to start IV fluids, even when the baby is breastfeeding very, very well. Okay, so IV fluids are only supposed to be started when there's signs of dehydration. The American Academy of Pediatrics put together a set of guidelines in 2022. They upgraded the old guidelines from, I think, 2004 or something, and they put together what they call key action statements. So there are about 25, yes, there are 25 key action statements, and they address quite a number of things, and IV fluids is one of it. Okay, so when there are signs of dehydration, fair enough, you can start your IV fluids. But if the baby is breastfeeding well, even when the baby is not breastfeeding so well, if the baby can take cup, then the mother can express. If you can pass an NG tube. But again, when there's signs of dehydration, that's when you start your IV fluid. So the main modes of treatment for neonatal jaundice is your phototherapy and exchange blood transfusion. There are quite a lot of new things coming up for its management, but they're all in the trial phases. Usually you have your intravenous immunoglobulins as well. I've put asterisks by antibiotics because it depends on the presentation. Sometimes you have a very well-looking baby coming in who is jaundice, breastfeeding well, no danger sign, nothing, in which case would not require antibiotics. But it's also vital that you identify the cause, like I mentioned earlier. It guides you in your management, how aggressive you are. It guides you in your counseling. And then it also has an impact on subsequent pregnancies. One book that we tend to underestimate is the Maternal and Child Health Record book. I always say that it has loads and loads of information in it. Fortunately, I think all Ghana health facilities, correct me if I'm wrong, they tend to test the mothers for the blood group, the rhesus typing, hepatitis B, sickling, G6PD screening, syphilis, all these ones are tested. So that means that you can have an idea of the mother's blood group. Because if the mother's blood group is O, then that means that there's a 50-50 chance that the baby jaundice could be due to ABO. So you'd want to check the baby's blood group. But if the mother's blood group is A positive, it rules out both ABO incompatibility and then rhesus incompatibility as well. So definitely it guides you when you're doing your investigations. So with regards to the investigations, you have your fractionated serum bilirubin. Then you have your transcranial transcutaneous bilirubinometer. Okay. Now, I'm not sure how many facilities are using it. Maybe Rich will be using it. I'm sure Charlene will be rolling her eyes at me. The TCB, what you should bear in mind is that TCB is a screening tool. It is not for monitoring. Once a baby starts phototherapy, you cannot use the TCB to measure the bilirubin. But before the baby is started on it, then you can use the TCB for that. But the TCB has also been found, the value from the TCB have also been found to be off by about 50 micromole per liter compared to the serum bilirubin. So you need to be careful about that. But it just guides you as to whether the levels are going up or not. And then once the levels are also higher than 250 micromole per liter, that's the 15 milligram per deciliter, then it's also been found to be unreliable. So these are things you can keep in mind when you're using the TCB. Then you have your full blood count, G6PD screening, then blood culture and sensitivity, urine culture, like I mentioned earlier, for prolonged jaundice, Klebsiella UTI, E. coli UTI have been known to be culprits for that. Then baby's blood group, like I explained earlier, either mother is O or RS is negative. Then direct Coombs test. Unfortunately, direct Coombs test also has it has a low sensitivity. So that means that even when it's positive, the chances are that in about a third of the cases, it would come back as negative, especially in very severe hemolysis. But at least it gives you an idea. What the direct Coombs test does is that it tells you, you see the antigen antibody complexes. So the mother's antibody binding to the fetal or the baby's red blood cells. So that is why, that means you're directly seeing the complexes, okay? Then reticulocyte count, blood smear for your hereditary spherocytosis and all that, and then serum albumin. So the investigations have to be tailored towards the baby's presentation. So phototherapy. Phototherapy is a visible use of blue light. But there's blue-green light, there's white light. It depends on the wavelength. But the most popular is the blue light. Blue lights falling in the wavelength, I think between 460, 420, and 490. The AAP says it has to be an average of 475 nanometers. Now, the dose of the phototherapy is key in how quickly it works, okay? However, the dose is in turn determined by the wavelength, like I said, average of 475 nanometers, the intensity of the light or the irradiance, okay? Then usually the irradiance is also affected by the distance between the light and the baby. And then how long, for lack of a better way to explain it, how long the lights have been used for. Because most manufacturers would say that after 2,000 hours, replace the bulbs, whether or not they are spoiled. But in our setting here, most of the time, we will only replace the bulbs when they go off, and not even when just one goes off, until all of them go off. Then we say, okay, yatieka, we want to replace it. Then the distance between the light and the baby, also per manufacturer's instructions, as well as the body surface area exposed to the light. Some people call phototherapy some kind of percutaneous drug. Okay, so the more of the body surface exposed to the light, the better. So what it does is to lower the serum bilirubin levels by converting it from the lipid-soluble form into water-soluble form. Once something is water-soluble, that means that it can easily be excreted in the stool and the urine. So basically what it does is to do the work of the liver, okay, because it bypasses the immature liver, okay, because the liver is not coping with doing the conjugation. It also prevents the need for exchange blood transfusion, and then it prevents the bilirubin from being deposited in the brain. So it's almost like a shortcut but manual version of removing, or should I say, it prevents the need for exchange blood transfusion. So when should phototherapy be started? There are Billy graphs for that, okay? There's so many different types of the graphs, okay? But at the end of the day, you just need to know the baby's postnatal age and then the serum bilirubin, and then you plot it. And some of the graphs look at, they combine it with risk factors. They look at the gestational age as well. So depending on where the baby's characteristics falls, then you plot it. The one in the middle is the new one by the AAP that they use for the AAP. So this one did not include the neurotoxicity risk factors, but they have another graph that combines the gestational ages with the neurotoxicity risk factors. Then, like I said, there's so many apps. You can have an app on your phone. This one is one of the apps. I think there's the AAP app also. So you just input the gestational age, the date of birth, the time that the bilirubin was taken, and then it will tell you whether the baby needs phototherapy and exchange blood transfusion. This one is from the NICE guidelines, the one used by NHS in the UK. So the one on the left, so they look at it, they have a different Billy graph for every gestational age. So I just picked the ones for 36 weeks and then for 28 weeks. So even when you look at it, you realize that for the same day and even the levels, if, for example, you have a baby, a 36-weeker with a serum bilirubin of 300, you'd see that it would plot at about 4 boxes above the phototherapy line. But if you have a 28-weeker with a serum bilirubin level of 300, you'd see that it plots 2 boxes above the exchange transfusion line. So then it gives you an idea that the gestational age has been taken into consideration with regards to these graphs. So I thought I would include something about nursing care during phototherapy. I think that you'd all agree with me that good nursing care would definitely contribute to minimizing side effects and complications of phototherapy. I mean, the efficacy with which phototherapy will work is in large part determined by good nursing care. The first one is effective irradiance and skin exposure. So the whole idea is to position the baby to provide maximum skin exposure as possible. The trunk being the biggest, providing the biggest surface area should be the target here. So if you look at the picture on the right, you notice that the light is shining basically on just on the feet of the baby. Okay, the rest, the upper part of the body is out of the phototherapy zone. Then the manufacturer will tell you, like I mentioned, the minimum distance between the phototherapy and the baby. So you'd have to adhere to that. Some would say it has to be between 15 to 20 cm, others 20 to 30. So once you read it, then it will tell you. In the past, when they were using halogen-based phototherapy lamps, then there were concerns about burns if the distance was too short. But I think that now most of the phototherapy units in use are LED based. Then thermoregulatory devices. Well, we've had issues with some phototherapy causing the babies to spike temperatures. In fact, I think recently some of our Firefly devices have been doing that. But if the baby is, say, in a radiant warmer, open or closed incubator, skin mode is preferred. So skin mode means that you set the temperature, incubator temperature, but it is not necessarily connected to the baby like you have in a servo mode. So then you have to be coming to check the baby's temperature and then adjusting the incubator temperature accordingly. Then I've already spoken about encouraging breastfeeding and breast milk feeding as much as possible. This will help reduce enterohepatic circulation. Then eye protection and eye care. There's a need for proper monitoring. I won't say much about it, but some studies have talked about issues with infections or trauma, and then interruption of mother-infant bonding because the eyes are always closed and are covered, okay? And then the mother thinks that she's coming to spend a short time with the baby, so why bother removing it? Then we know that there's some kind of osmotic diarrhea in phototherapy as one of the side effects. So the mother will complain that the baby is having frequent stool. Okay. So that means that there's a possibility that there could be compromising of the skin integrity, okay, because of the frequent stools. So then the mother needs to be taught how to clean the place to prevent skin rashes and all that. Then education is always important. The mother has to understand why the baby is receiving the phototherapy. Are there any possible side effects, etc., etc. So then we come to exchange blood transfusion. Basically, it entails removing aliquots of the baby's blood and replacing it with donor blood in order to remove abnormal components. So here, abnormal components, we're referring to bilirubin. It could also be maternal antibodies that's causing the hemolysis. Whilst you're doing this, it's all the while you're trying to maintain adequate circulating blood volume. So you remove it, you replace, you remove it, you replace with the donor blood. Now, the threshold to initiate exchange blood transfusion takes into consideration several factors. So the SBR level, the rate of bilirubin rise, the age since birth. If I have a baby coming in with an SBR of 200 and the baby is, say, 20 hours old, I mean, the urgency with which I would approach such a baby is so different from a baby who comes in at 4 days, 5 hours old with the same level of bilirubin. Then, of course, signs of neurologic implications. The mother tells you that, no, this is not how the baby was breastfeeding before. And the baby has become even more weak now. So now I have to express and give to the baby. But he was suckling very well previously. So all these factors that I've mentioned are also what indications for referral or advanced care if you are not in a position to do an exchange blood transfusion in your facility. Then again, use of the billigraphs, okay? It is always good to get an objective assessment. You have the serum bilirubin, you have the time that it was taken, you know how old the baby is at the time when the sample was taken, not at the time when you get the result. You plot it. If it says it's about phototherapy, you give phototherapy. If it's about exchange, then you proceed. But sometimes the baby comes in and you do not say that you're waiting for the results. A baby comes in yellow from head to toe. The baby has a fever, which is a danger sign. Because the presence of a danger sign makes the brain more vulnerable to the damaging effects of the bilirubin. So there are times when even as you've sent the samples, you're already preparing for an exchange blood transfusion because the longer you wait, the higher the chance that the baby will end up with the bilirubin encephalopathy. So I can't talk about jaundice without talking about sunlight therapy, and I like to call it Lion King therapy, okay? I put this picture there because I always imagine the one holding the baby is the grandmother, then the lion, what's the name of the male lion cry? That one is the great grandmother, and then you have the baby's mother standing by, because most of the time the grandmothers will take over the looking after the baby. So the thing with sunlight therapy is that it works for physiological jaundice, but unfortunately it's difficult to tell when the jaundice is physiological in nature. Okay, so it's always best to err on the side of caution. Okay, so there's also the issue of the prolonged exposure to UV rays being harmful to the developing skin. I mean, here's a newborn, the skin is still developing, it's not matured yet. So once you expose it to the UV light, then it can affect how the skin develops. Then the argument is that if you're worried enough to want to do lion kin, then bring the baby to the hospital. You must always err on the side of caution, okay, at least where jaundice is concerned. The least you can do is to check the baby's SBR. If a mother sees that the baby has become jaundice and comes all the way to the hospital and tells you that my baby's eyes have become yellow, you don't say that panicotre anoperia. Okay, so then she comes back and now the baby is showing signs of what? Encephalopathy, and it's too late. Now, some studies have been done into the use of filtered sunlight phototherapy. I think Nigeria has done some work on that in collaboration with Stanford University, I think. So what they did was that they got a film and then a tent or some kind of canopy. So the babies are outside in the sunlight. Now, what the tent and the film do in combination is that they how do you call it? They filter out the UV rays and then the infrared rays, okay? So that whatever is coming to the baby is safe, okay? I really don't know whether they're using it in some of their hospitals there. So recommendations. There are quite a number, but I just decided to do a few. The need to encourage early and exclusive breastfeeding. So the question I was asking myself is, are we still doing the health facility, the breastfeeding initiative thingy, where you go and you certify, you accredit a health facility as being baby friendly? Okay, in the CAF study, there were certain factors that were associated with increased survival, okay, primiparity, and then exclusive breastfeeding at the time of admission, okay, those were associated with survival. Then there's also the need for standardized protocols for early identification, management, and referral of jaundice cases. The AAP key action statements, one of the suggestions was that for all babies born in the health facility, you can do just visual assessment or visual inspection every 12 hours. Okay, that is for those who are not jaundiced. But as soon as you can physically see that the baby or there's a hint of jaundice, then you'd have to do what? The serum bilirubin. You can also use the TCB to check. Okay, so I put these in question marks here because then I'm asking, is it something that we can do here? Which brings me to equipment. Aside from talking about the usual, we need phototherapy machines, Firefly devices, etc., etc. There's also the need to at least equip our ambulances that transport newborns with Billy blankets. Billy blankets would allow for what? Continuation or initiation of phototherapy for severely jaundiced babies who are being transferred for advanced care. Because remember that phototherapy starts, I mean, it's instantaneous. Once the light is on, then the conversion will start. I've already spoken about the visual assessment, TCB before till discharge, then education, okay, like we're doing with the Jaundice Awareness Month, but it shouldn't be only in the month of May, it should be year round. So in conclusion, we need to remember what is at stake. If we do not detect it early and put interventions in place, there will be dire and irreversible consequences, eventually leading to death. We're talking about deafness, mental retardation, cerebral palsy, etc., etc. Then there's also the issue of when to discharge our babies, especially those who are delivered via SVD. Sometimes within 6 hours they've been discharged. And what are the chances that the mother will come back? And for those that we are discharging, do we consider risk factors? I mean, if you're discharging a baby early and the mother is O positive, okay, is it something that would make you delay the discharge or even plan a postnatal review visit earlier? If you're not sure, always ask for a second opinion. I mean, this is somebody's life you're talking about. You miss it, even a day or some hours will make a difference. You miss it in the morning, by the time she comes back in the evening, what has happened has happened. Then, so eventually, prevention, prompt and adequate treatment of neonatal jaundice will not only massively contribute towards achieving SDG 3, but would also make achieving SDG 8 more achievable, since the contribution of severe jaundice to the number of disabled in the population will also be what significantly reduced. Thank you very much. I think I've stuck to the time.
You're just over by 3 minutes, but that's fine. Thank you so much. I'll call this a revision course 101. I would have loved to be a pediatric resident at this particular time because I definitely would not have gone back to read on neonatal jaundice. Thank you so much, Dr. Grobe, for this very educative platform and teaching us everything we need to know. Almost everything. I don't think you missed anything, but just in case, we can never say never. So for teaching us almost everything about neonatal jaundice, the medical courses and the management. Importantly, you did mention that the maternal child health record is very important.
I think you started breaking. I don't know whether it's just me. Nanama.
People feel
Hello, it's breaking. I don't think it's only you.
Apologies, please. The moderator has dropped off and our capacity is full, so we are trying to get her to join. Please give us some few minutes. Thank you.
Hi, whilst we wait for the moderator to join, may I suggest that the next presenter starts? I think Dr. Techua is the next presenter. So, Doc, if you are ready, I think you can start. I'm sure we'll get our moderator back. Thank you, and over.
Hi. Good evening, everyone. Can I share my slides now?
all right. We are so sorry about that. Please, can I be heard?
Yes, please, we can hear you.
Yes, we can hear you.
Thank you so very much, Dr. Nana Rekubrobe, for that. So without wasting much time, because I've already lost so much time, thanks to our network, we will go on to talk about the surgical courses and management. And to do this for us, we have Dr. Mamite Chua Botre. She is the founder and executive director for Hope of Little Lives. She's also a lecturer at Accra College of Medicine. And to crown it all, she's a pediatric surgeon with the Greater Accra Regional Hospital. Dr. Techua, the floor is yours. Dr. Botre, please, you are muted. Sorry.
Thank you very much, Nanama. Can you all see my screen?
Yes.
Okay.
Please, just before you launch, a quick reminder. So we've shared the YouTube link, which you can share with others. All the over 200 participants who have joined our YouTube. Questions and answers are welcome. There, your questions will be asked. Our earlier printers, they can save us some time. Thank you very much.
Okay, thank you very much. Can you see my screen?
Yes, please.
Okay, thank you very much for the opportunity to share some surgical knowledge on neonatal jaundice, and happy Yellow Month to you all. I must say that it's a bit of a short, 20 minutes is very short to talk about all the surgical pathologies causing neonatal jaundice, but I'm going to do my very best to give a general overview and make sure that I impact as much knowledge as much as possible. After Dr. Rekubrobe has come to wash and hang and dry, I'll do my very best. So this is the outline, a bit of introduction, anatomy and physiology. I can't talk about anything as a surgeon without talking about anatomy, the surgical courses, overview of individual pathologies, conclusion, and questions. So by way of introduction, 6 in every 10 newborn will have jaundice, and out of the 20 newborns who have jaundice, 1 will have elevated bilirubin needing treatment. I must say that majority of newborn jaundice is caused by, is medical, just less than 20% are surgical. And whenever a child presents, I can't overemphasize what Dr. Rekubrobe said. We need to thoroughly investigate and evaluate every newborn jaundice. For a mother to leave the house to come to the hospital, it means that the mom was desperate, and we need to at least investigate. As pediatric surgeons, we are consulted when the jaundice is prolonged, when it's progressive, and when it's associated with pale stools. So a bit of anatomy to understand some of the pathologies. So bile is secreted in the liver, and after it's transported through the hepatic duct, you have the left and right, which joins to form the common hepatic duct. Then it is stored temporarily in the gallbladder, and then is released through the cystic duct. And the cystic duct and the common hepatic duct forms the common bile duct, which is further joined by the pancreatic duct downstream and emptied into the second part of the duodenum. As parts of biliary metabolism, Dr. Rekubrobe mentioned, gave an overview of it. But for surgical causes of jaundice, we will be looking after 4, where after conjugation by the liver, it's transported downstream. So most of the causes of jaundice surgically are after conjugation. So they tend to have conjugated hyperbilirubinemia. So the causes are biliary atresia, choledochal cyst, biliary hypoplasia, also known as Alagille syndrome, and speciated bowel syndrome, spontaneous perforation of the common bile duct, any extramural compression of the common bile duct. The top 2 are the common ones we've seen. Personally, I haven't seen an Alagille syndrome before or an speciated bowel syndrome before. So biliary atresia, I'm sure most of the pediatricians have heard of biliary atresia, or you may have seen one. So it's just progressive disease. It's a progressive disease characterized by inflammation and fibrosis of the extrahepatic biliary system. And this leads to partial or complete obliteration of the biliary duct. When this happens, there's impairment of bile flow downstream. This back pressure subsequently causes portal tract edema. bile duct proliferation, portal and periductal inflammation, and eventually it leads to irreversible liver damage. The exact cause of biliary atresia is not known. However, there are certain postulated theories. People believe that during the perinatal period, infections with cytomegalovirus, rotavirus, Epstein-Barr virus can predispose the neonate to having, the fetus to having biliary atresia. There are other autoimmune insults, vascular metabolic insults, as well as there's something called abnormal ductal plate remodeling, and also exposure to different toxins from the mother. I must say that biliary atresia is not always in isolation. There's a percentage of them, about 20%, which is syndromic. So once you see biliary atresia, there are other associated anomalies such as polysplenia, duodenal atresia, situs inversus, congenital, dextrocardia. So you need to investigate thoroughly when you have a child with biliary atresia. So how do they present? They normally present with progressive jaundice. So jaundice at the onset of birth, which progresses. For the term babies, we say more than 2 weeks, you should be concerned. For the preterm, more than 3 weeks, you should be concerned. They also present with dark urine, pale stools, pruritus, and my apologies, it's not purities, it's pruritus, hepatosplenomegaly. And if it progresses without any intervention, it leads to liver failure, and they may present with the stigmata of liver failure. So how do you diagnose it? So the diagnosis, I always tell students, residents, medical students that you always divide it into supportive and the diagnostic diagnosis. So for the supportive, once you do your bloods, you see that there's elevated bilirubin. Depending on where the lab is done, it's either increased conjugated, some people call it direct bilirubin. When you look at your transaminases, your ALT, AST, it may be mild to moderately elevated. There's also significant elevation of your ductal enzymes, especially your GGT. Your GGT is markedly increased, more than your ALP. Some people do a HIDA scan. We don't do it routinely, but some jurisdictions, they do it. And HIDA scan is basically a radioisotope scan, which assesses to see if there's secretion of bile. And once the liver hepatocyte picks it up, which you see on the image, and it means that there's no obstruction. So it rules out any obstruction, but if it is negative, it doesn't necessarily say that's biliary atresia. It could be other causes of obstruction. Another thing that you do is a fasting abdominal ultrasound. I say fasting because you need to fast the baby to ensure that there's adequate filling to give the gallbladder enough room, for the gallbladder to fill. And on ultrasound, what you see is that you may see an absent gallbladder. You may see a shrunken and atretic gallbladder. There are other signs that you would see, but I'm not going to bore you all. It's for the radiologists and the pediatric surgeons, like a triangular cord sign. You don't see any dilatation of the biliary tree, but what you do is a fasting abdominal ultrasound. So for your diagnostic investigation, what you do is an on-table cholangiogram, where you take the baby to the theater, you do a mini laparotomy initially, then you inject contrast into the gallbladder under screening, fluoroscopy. So you want to see whether there's going to be bile flow downstream. After you do that, you'll be able to know whether you should proceed or not to proceed. As part of that, we do a liver biopsy as well. So the treatment for biliary atresia is Kasai portoenterostomy, where we resect the atretic, extrahepatic biliary system, and then we do we connect the bile to the portal system. In doing that, there are other medical managements that you need to do. So we also, before we prepare for surgery, it's not just taken to surgery, you need to prepare the patient adequately, make sure that the clotting profile is fine. You need to give vitamin K and other fat-soluble vitamins. You need to give antibiotics. You need to make sure there's blood in theater. So it's not like, I think it's a biliary atresia. I'm pushing to the surgeons. There's a lot of workup that you need to do. Post-operatively as well, You need to give Phenobarb, which helps with bowel flow. There's steroids that you need to go. Like I said, is a chronic inflammation that has been going on. So it's believed that the steroid halts or prevents further damage of the biliary system. So you need to give steroids for a period and then you taper it down. There are some patients who present quite late, and such patients will need a liver transplant. Even after Kasai portal enterostomy, some of them fail and they may end up needing liver transplant. So the prognosis of biliary atresia, it depends on the time of intervention. Literature says that it's better before. It used to be 90 days, but it's better if you operate on them before 60 days of life. There's something called the rule of threes. So when you, even if a patient presents early and then you do your Kasai portal enterostomy, 1/3 of them will be fine. They'll not need any further intervention. 1/3 of them will partially drain, meaning that they'll drain for a while, and after they'll stop draining, needing transplants. 1/3 of them, the Kasai will not work at all, and they'll need transplant. Also, post-biliary atresia treatment, you need to watch out for complications. They may come in with ascending cholangitis, and if you don't pick up this early, it can be very fulminant. Since the pediatricians are the frontline child caregivers, you need to have a high index of suspicion for this so that you aggressively manage them. Some of them can also present to portal hypertension, especially those who have the failed and the partially drained. They may come in with upper GI bleeds, and this can be very, very torrential. And you need to be very aggressive and have a high index of suspicion and know their medical history. Know that this patient previously had surgery for biliary atresia, so I need to call the surgeons as soon as possible. I put here that time is not a luxury in biliary atresia. There's a critical window, and once you pass this critical window, after you do your Kasai, you are just doing it just to make the parents happy. It will not necessarily work. An important nugget I want to tell you is that there's some similarity between, I know the pediatricians, you know about idiopathic neonatal hepatitis. So there's some similarity between the two, biliary atresia and idiopathic neonatal hepatitis. So you need to know that the sexes are different, the incidence is different. Usually idiopathic neonatal hepatitis is common with preterm babies, low birth weight, and small for gestational age. Also, there's no associated anomaly. They also have pale stool, but it's intermittent. It's not as persistent as biliary atresia. So just have this in mind, especially for academic reasons. The next I want to talk about is choledochal cyst. I'm not going to worry about the classification and the types. So choledochal cyst basically is congenital dilatation of the biliary tree. And there are two main etiologies. The first one is malunion of the pancreaticobiliary duct. Remember I told you that you have your common bile duct joining the pancreatic duct to enter the second part of the duodenum. So when there's a malunion of this, there's something we call a long common channel. And this long common channel results in reflux of pancreatic juices into the biliary system. And pancreatic juice is alkaline, and it's a bit toxic to the bowel wall. So with time, it destroys the muscle layer, the enterocytes, and then it leads to weakening of the muscular wall of the biliary duct. Another etiology is obstruction of the distal common bile duct. So how do they present? Usually choledochal cysts can present during the neonatal period, or they can bypass the neonatal period without necessarily being picked up and present during in older children. Some adults also present with choledochal cysts. They miss the neonatal period, they miss the infantile, adolescent, teens, and then they present during adult years. But because we are talking about pediatric, I'm just going to focus on pediatric. So choledochal cysts can be detected antenatally, where the OBGYN or the fetal-maternal specialist picks up a cystic dilatation around the biliary tree during pregnancy and can refer to the pediatrician or the pediatric surgeon. Also, during the newborn life, they present with jaundice. This jaundice, unlike biliary atresia, is intermittent and is not as deep and is not prolonged. they can also have pills too. Quite a small percentage of them, I mean, not so small, significant percentage of them can have pills too. So when you see pills, you don't think that, oh, it's biliary atresia. It can still be a choledochal cyst. Also, for the older children, they may present it with recurrent abdominal pain or just abdominal discomfort with or without intermittent jaundice and abdominal mass. There's a triad we call. So the older kids can present with a triad, which is very pathognomic of choledochal cysts. So abdominal mass, jaundice with recurrent abdominal pain, you should think of choledochal cysts. They may also present with features of ascending cholangitis, where they'll come in very sick with a fever, deranged liver enzymes, increased ductal enzymes, and you should suspect choledochal cysts. So for your investigations, there's a supportive and diagnostic investigations as usual. So the supportive, you have your elevated bilirubins, mostly your conjugated or direct. They have very, very mild transaminitis as compared to biliary atresia. Also, the ductal enzymes are increased, and for choledochal cyst, it's more of the ALP as compared to the GGT, whereas in biliary atresia, there's a vast variation between the two ductal enzymes, where GGT is more elevated. Also, you do an abdominal ultrasound. It doesn't need to be a fasting ultrasound because you're not necessarily looking at, your attention is not on the gallbladder. You just want to see the extrahepatic biliary system, where you see dilatation. Any dilatation of the extrahepatic biliary system should prompt further investigations. So for your diagnostic investigation, you want to do an MRCP. In a part of the world where we don't have an MRCP, an abdominal ultrasound will surface, or some people go ahead to do a CT scan, but a CT scan is not that sensitive in picking it up. But once you have an abdominal ultrasound, you have a high index of suspicion from the presentation and the labs, you can go to theater and just explore and see. So an MRCP is preferred, especially in young children, because there's no radiation. However, sometimes getting the appropriate size, instruments for neonates is a bit difficult. So some people end up doing ERCP, which can be therapeutic as well, especially for older children. So the treatment for choledochal cyst is a Roux-en-Y hepaticojejunostomy, ignore the storm, or a hepaticoduodenostomy, where we excise the portion with a cyst and then join it to a portion of the bowel. Some people decide to use a jejunum, some people decide to use a duodenum. However, there are times where there's recurrent cholangitis. So there's a lot of adhesions, and it's very, very difficult to just excise the sac, excise the cyst, and do your hepaticojejunostomy or your hepaticoduodenostomy without compromising very important structures such as the aorta, the vena cava. So there's a procedure we call Lily's procedure, where you deroof and then leave the posterior wall of the cyst so that you don't injure vascular structures. The prognosis for choledochal cyst is usually good. However, I must state that there's a risk of malignancy. About 10 to 15% may have malignancy in future, and they tend to have cholangiosarcoma. So you need to investigate them. Some people have a high index of suspicion when the patient comes and has, non-specific abdominal pain, or has abnormal increased routine blood investigations and has increased bilirubins, or comes with jaundice. You need to probe further and know what the history is. But this is outside our care, usually when they transition into adulthood. So this is biliary hypoplasia. It's not that common. Like I said, I haven't seen one before. So Alagille syndrome can be isolated or it can be systemic. So they tend to have other problems with vision, blood clots, they have developmental delays, they have cardiac issues, they have cholesterol issues. And basically, in regards to what we are talking about, they tend to have reduced number of intrahepatic bile ducts. And like I said, the etiology is unknown. It can occur in isolation or part of the arteriohepatic dysplasia. If it's isolated, the diagnostic evaluation is just like biliary atresia. You will do your on-table cholangiogram. You want to do your bloods to rule out other medical causes. For the mild disease, you can manage conservatively. However, if it's a very serious disease, you treat it as biliary atresia. Spontaneous common bile duct perforation, the exact cause is unknown. They not usually present with a delayed onset of jaundice. It may be insidious or it may be acute. They may have abdominal distension. They may have a pigmented umbilicus. They may have a chylocele if because of the rupture and fluid in the peritoneal cavity, it may drain into the scrotum. So they may have a chylocele in the scrotum, especially when there's a patent processus vaginalis. By way of supportive investigation, you can do an abdominal ultrasound, and you may see fluid in the subhepatic space. And this fluid is not regular fluid, like it's a collection of fluid, a bilioma, which you may see. So to intervene, after you do all your bloods, the same routine bloods that you do, you would manage this by doing an exploratory laparotomy. You repair the perforation. If it's a very small perforation, you just repair it and insert a T-tube. Or if it's quite extensive with a lot of adhesions, you may end up doing a hepaticojejunostomy. So inspissated bowel syndrome is not a condition on its own. It's basically as a result of some mechanical obstruction of the biliary system. And there are so many conditions that can cause this. Some are cystic fibrosis, ABO incompatibility, which causes a lot of, thick sludge in the biliary system. And they are mild, and it ranges from, the severity is from mild to severe. And you need thorough evaluation of the patient. So in evaluating them, you tend to realize that that's not the diagnosis, but there are other conditions that are causing this, and you need to manage those conditions like meconium ileus disease, cystic fibrosis, etc., etc. For the mild disease, it can improve with time. However, if it's very severe, you may need to take action. You may need to give Phenobab, which helps with bile flow, and you may have to do an ERCP, especially if it's an older child. Do an ERCP, and then you irrigate the biliary system. So in conclusion, neonatal jaundice can be I can't overemphasize this. It can be very, very stressful for parents and guardians. And as clinicians, when they come to us, we shouldn't trivialize the caregiver's concern and say that, oh, it's nothing. Just like Dr. Reku Brobe said, for a mom to leave the house and come all the way to the hospital, you should be concerned. A listening ear and thorough investigation or evaluation can go a long way. And let's remember that surgical causes is just less than 2% of the the general causes of neonatal jaundice. So let's try and rule out all the medical causes, Wilson disease, glycogen storage disease, the rare causes. These days, with intercontinental marriages and everything, before, certain diseases were just for the white, but these days, because of mixed race, we should try and rule all the other causes. And when we are ruling the other causes, we should remember that 2% of these causes is by biliary atresia, choledocalcis, or any of the other conditions that I mentioned. And for biliary atresia, time is not a luxury. I want to repeat again, time is not a luxury. So let's remember that. Thank you very much. I hope I was within time. And I have two questions. My question is, and I think that's what everybody is talking about, how early should we discharge post-delivery? In some places, you need to be kept in hospital for at least 24 hours after you deliver for you to be thoroughly examined before you are discharged. Also, should we start doing routine newborn screening? It's just a question I'm throwing in the air. Thank you very much.
Thank you very much, Dr. Mamete Chua-Botry. Please, can you help confirm if you can hear me?
Yes, I can hear you.
Awesome. So thank you so much. And certainly, I like the fact that we didn't only focus on the medical courses, but we're also talking about the surgical courses. And a reminder that with biliary atresia, time is of the essence. Please, let's not ignore a mother's concern of yellowing. The least you can do is at least do the serum bilirubin and find out what your numbers are. And then you can send them home if really there's no need for intervention. Thank you all so much. Our speakers so far have been wonderful. We don't want to spend too much time. We just want to remind you that questions and answers are still ongoing in the chats. Please post them. At the end of the session, the floor will be open for those who need further clarification so we can do that. Earlier on, Dr. Sirbo, GMA president, was to join us, but unfortunately, he sent his apologies for not being able to do so. So we're moving on. The final presentation for the day. We're talking about strategies for improved care across Ghana, the role of healthcare provider, the healthcare system, and stakeholders. And I think we chose the best person to do this, and he's in the person of Dr. Nana Okai Bracon. Everyone who knows him knows he's passionate about neonates and newborn care, and he's going to be taking us through this. So, Dr. Bracon, your audience, the floor is yours.
Hello. Please, can
Yes.
I be heard?
Yes, please.
Okay, good, great. I'm Nana Okaimbrako. I'm going to take you through. Good evening, everybody. I'm happy to be part of this, as usual. And I'm going to talk about strategies for improved neonatal jaundice care across Ghana. I have 15 minutes, so the game starts. So this will be the outline of my presentation, a bit of introduction, role of leadership, the healthcare provider, healthcare system, stakeholders, and then general public. So as part of the introduction, we want to know that neonatal jaundice is, as we already have learned, yellowish discoloration of the skin, sclera, mucous membranes of the newborn due to excessive accumulation of bilirubin, an end product of metabolism of heme from the breakdown of hemoglobin. And we know that newborn jaundice was discovered in the 17th century. And as we know, 60% of term babies and 80% of term preterms born may develop neonatal jaundice. So it's very, very common in the neonatal period. And institutional data points out to the fact that it's the leading cause of morbidity at OPD attendance during the neonatal period. This is a known public health concern over the years, but very little advocacy and awareness creation activities have been carried out until 2018, when the leadership of Pediatric Society of Ghana instituted the month of May as the Yellow Month. This marks the beginning of a new era in developing strategies for improved neonatal jaundice care across the country. Now, we have to know that a multifaceted approach, which involved coordinated efforts from PSG leadership, engagement with stakeholders, healthcare systems, healthcare providers, and the general public, especially a hype by the media, was taken into consideration. The role of healthcare providers was so important because early detection and diagnosis is key in saving our babies from the complications of neonatal jaundice, where clinical inspection of jaundice in all neonates within the first 24 to 48 hours of life was instituted. We took the midwives through a lot of trainings, because we know that at every birth there should be one person whose sole responsibility is the baby and who can help in helping the baby survive. But thereafter, we have to be able to take data. For instance, when it's O negative mother, or all those O positive mothers and things, we should be able to coordinate and tell them the risk factors that are associated with that. Now, training in the use of transcutaneous bilirubineometer was also instituted in some facilities, and then some facility heads, which is leadership, were able to procure some, and some are being used as of now, but then it's in the minority. There was prompt use of total serum bilirubin testing across the country, especially in district and regional hospitals, because as we know, the healthcare system, when it comes to neonatal jaundice, in the beginning was centralized, because most of the patients were being referred or sent to district and regional hospitals, district, regional, and teaching hospitals. Those were the areas where we could get the phototherapy units, especially the fireflies, and then the intensive phototherapy, and then the professionals who are to undertake blood exchange transfusion, and then further investigated cases were there. But then, as the years passed by, we were able to train a bit more of pediatricians, so the coverage is a bit better. And as we know, we started forming what we call the levels of healthcare. Okay, where we have 1 to 3. We have 1, we have 2, 2A, 2B, and then the 3, where the 2As are all supposed to have pediatricians. So because of that, we started moving from centralized care to decentralization of neonatal jaundice. Now, the capacity building and training. Regular in-service training and updates on current guidelines for neonatal jaundice normally is done in hospitals with pediatricians, and with the help of what we call the newborn focal persons. Such things are a bit more disseminated into the system. The inclusion of neonatal jaundice protocols in nursing and medical curriculum is another thing that was also proposed, and it is there, only that it's left with us to emphasize or maybe give a guideline as to how it's supposed to be taught, because all medical students, that's house officers that come out, they all have ideas of all these conditions, but then it's left with how deep we go into it, so that as they come out, they can use it efficiently. Timely intervention is very, very important. As we've already said, early initiation of phototherapy and appropriate referral for exchange blood transfusion, if needed, is very, very vital. We have so many delays in this. We have the first delay, second delay, and third delays. Sometimes the decision to come is a problem. Sometimes the way to get to the place is another. And sometimes they are able to get there. They come. But then for us to be able to effectively manage them becomes another challenge, because blood products are sometimes very difficult to get. You want to do blood exchange transfusion, your institution doesn't have, you have to refer the people or send the people to go around searching for blood. There is no coordination between the blood banks where we can get a motorcycle or some form of drone or anything sending blood from one area to the other. So parents have to go around searching for those kind of bloods. And I think all these things are third level of delays that can work on. We have to also ensure effective monitoring during phototherapy. It's already been elaborated by the first presenter, that's Dr. Nanakweku, and we have to know that hydration status, as she said, is very important. Temperature and then bilirubin levels are 3 things we have to take into consideration. Now, when we talk about the healthcare system, we are talking about infrastructure and equipment. We are talking about standardized protocols And we are also talking about data surveillance. So when we talk about infrastructure and equipment, we are talking about advocacy, provision of functional phototherapy units and bilirubin measuring devices in the healthcare facility. I have already said we started a centralized one. For instance, if you take something like Greater Accra region, which is one of the highly densely populated areas, we realized that we can't get phototherapy across the country. So we set up a pool of phototherapy at the regional hospital, where we initially invited all cases to come for that management. So it became like a neonatal jaundice corner for the region. But then subsequently with more training in the field of pediatrics with specialists all over the district hospitals, we decided to decentralize it, where the facilities were tasked to get their own phototherapy units so that they can start some initial phototherapy till their conditions are unable to be managed, and they can refer them to the central point. Maintenance programs to ensure continued functionality of equipment was also put in place across the nation. But also, as usual, we don't have so many biomedical engineers, but for the regional hospitals and district hospitals, they've been an initiative to send biomedical engineers, and they also formed what we call the central point of care biomedical engineers, which are the regional biomedical engineers, which can also move to other places when it comes to the care and the maintenance of equipment. I know for now, a lot of biomedical engineers, due to all these, some have been sent to other countries, such as South Korea and things, and they've been trained to try and then manage this kind of equipment and others. We have standardized protocols. As Dr. Reku Brube has already mentioned, implementation of national protocols for screening and diagnosis and management of neonatal jaundice is very, very vital. Something has been started. Normally, people do use the nice guideline 2010, but we have the WHO and the British and the others, and so many others that can be used. But these are some of the very common ones that we apply at the bedside in the management of neonatal jaundice. We also have developed a referral system pathway to higher level care for severe cases. And most of the regions now have what we call the WhatsApp platform groups, which identifies cases and then prompt referral to other higher institutions are done. We also do that by phone calls, calling of colleagues, because now most of us know where our other colleagues are, so we easily reach to them on phone, so that such severe cases can be referred to such areas. The ambulance service is one area that occasionally helping all this referral pathway system, but only that I think we are still paying for ambulance service, which is quite expensive. So it really does not augur well in the transport system. So you see many people still coming in taxis and private cars to the institutions, even sometimes with severe cases, which shouldn't happen. Now, the zonal concept, it's something that we initiated as soon as the centralization of care came to play. So when it got to the time for decentralization, we decided to create what we call the zonal. We zoned the regions. Kumasi have been zoned, Accra has been zoned. I know many other regions have been zoned, so that in one small zone, you create something like a central system where cases are moved from the sub-district to the district level for care in a zone, so that you don't have to really travel that very long stretches for care. In the past, we know the best is the teaching hospitals, so we tend to refer from even sub-districts straight to the teaching hospitals. But now a lot is being done so that the district levels can hold onto the sub-district cases and refer the ones that are quite severe. So all these are system issues that is being managed. Now, data and surveillance when it comes to neonatal jaundice. Jaundice was not picked up in the DIMS until about 2022, when we got to the peak of advocacy for neonatal jaundice, where a lot of stakeholders came to play. So part of the stakeholders who came to play is the ministry itself, the Ghana Health Service, the Family Health Division of the Ghana Health Service, WHO, UNICEF. Then we have some NGOs also coming to help in that, to that regard. We had the MEPSI, and then we have the PATH coming in, and then we had the African Health Supplies also delving into procuring neonatal equipment for the nation. So all these things were things that had gone on since 2018, something that should have been there proud, because this is not a new condition. It's a condition that have lived with us all over these years. So when we talk about the stakeholders, we are talking about policy and funding, where inclusion of neonatal jaundice care in national child health policy frameworks now came to play. Allocation of funds for equipment procurement, health worker training, and community education was not really taken over. It was the Pediatric Society of Ghana which still led that kind of intervention. But then the DDCCs of all the regions were also tasked to, that's Deputy Director Clinical Care, they were also tasked to play a role in making sure the district hospitals and the regional hospitals were able to procure what it takes to manage neonatal jaundice. And to that regard, leadership came in, and many hospitals, especially the district hospitals, who generate a bit, channeled part of their funding and procuring a type of phototherapy unit or two. So if you take an example, Accra as an example, we have so many district hospitals who have self-financed the procurement of phototherapy units. Also, the Pediatric Society of Ghana formed a fundraising committee which were able to raise funds to procure some neonatal jaundice equipment, which were donated to many other regions, such as the Volta region, which I witnessed it at one of the hotels. It was launched, which was it was so touching to be at that very ceremony. When it comes to research and innovation, we have to support local research into the prevalence, causes, outcomes of neonatal jaundice in Ghana. And once we have been able to place it as an indicator on DIMS, we've started getting data on neonatal jaundice. We started with 0, but now I think about we have some of the regions have as high as 20 to 30% coverage. So the role of partners in healthcare services and NGOs are very, very important. For partners, I've mentioned some, the UNICEF, the WHO, are two main ones that normally help in such instances. And then the NGOs, we mentioned the PATH and MEPSI that are in 4 regions of the country, and they are helping so much in equipping them. We have to also encourage innovation in low-cost jaundice detection and treatment technologies. For that, I think the Firefly never existed in the country, but with the advocacy, the African Health Supplies were able to bring Firefly. Initially, what we had was what we call the East Meet West. I think it's the same company, maybe. If not, I can correct it. And now we have so much in the system. Partners and advocacy. So we collaborate with NGOs and private sectors to expand outreach and then educational programs. We have other partners and NGOs, something like you can take a partner like Kofi. Kofi is in the Volta region. Yeah, I think Volta region, Oti, all those areas, also helping with advocacy and getting equipment for the management of neonatal jaundice. We also advocate for inclusion of neonatal health in broader maternal and child health initiatives. Because, as you know, if you take other broader maternal and child health initiatives, something like breast cancer awareness month, breastfeeding, all those things are things that we try to put jaundice under, because they are all preventive ways. So if you breastfeed your child well, the incidence of jaundice tend to be a bit lower. And then because they are hydrated, they are fine. So no enterohepatic circulation and all those kinds. So we try to merge them. And if you breastfeed the baby very well, it's like it also reduces the incidence of cancer and all those things in them. So we try to merge them to make a story out of them, so that the advocacy would be around the clock. It means 24/7 and also all year round. When it comes to the public, community-based education programs to raise awareness of neonatal jaundice symptoms and danger signs is also very important, where we have the role of the newborn champions, where newborn champions are, we'll say, traditional rulers, chiefs and traditional rulers. Let me just put it that way. The chiefs, and then they are and prominent people in society. Sometimes we call them, bring them together to form what we call the newborn champions. Every region has one, which helps to disseminate information when it comes to the community level. They have a national chair for that newborn champions. It's a recognized group which can be used. So if you don't know it exists, we can make good use of them by making sure you get into contact with the regional directorates where they have the list of them and you can use them. We can empower caregivers to seeking early medical attention for yellowing of the eyes and skin. through public lectures. We do Yellow Month awareness activities as we are doing, and sometimes you have to go to the level of creating awareness in the communities, okay, by seeing the point of entry, the chiefs. Sometimes you create other awareness by letting them do the gong gong, like in some villages I know, which really works very well. Cultural beliefs and practices. We address harmful traditional practices that delay care, okay, like reliance on herbal remedies, using of breast milk on the eye when it's very, very yellow, thinking it's an eye infection, instead of seeing to going to the healthcare, the health facilities. So it's very, very important to make sure harmful traditional practices are eliminated so that we do. And by so doing, Pediatric Society is doing very well. We were able to create awareness per region. Every region has something small to do every May of every year, and we think that should carry on. And we promote positive health-seeking behaviors through community influencers and then religious leaders. Debates sometimes are organized where nurses and health persons are invited to give talks to the community. I think neonatal jaundice should be one of those talks that we should encourage, that is always highlighted. Postnatal follow-up. When it comes to regional and district hospital and teaching hospitals, sometimes the 2-day postnatal follow-up is not really in play, but when it comes to the district and sub-district level, they normally really patronize the 2 postnatal visits, where jaundice is normally picked and managed accordingly. We have to also promote breastfeeding, which can help reduce the risk of neonatal jaundice. So when it comes to postnatal follow-up, it's very, very important. There was a question about how long should it take a mother should stay after delivery in the hospital. And we know low and middle income countries normally are practicing what we call early discharge, which is 24 hours of stay. But then normally they have to be able to stay 40 to 72 hours in the hospital so that they get adequate education, care, and the management of these very early complications that can come with the babies. But really, in our circumstance, sometimes 6 to 8 hours after delivery, you can be discharged. Challenges and recommendation, I had to launch them together because the challenges would come with its recommendation as we solve them. We want year-round advocacy because we don't have, and we are trying to merge neonatal jaundice with other existing activities so that we can make sure we carry it through year-round. Funding for equipment and logistics, it's a challenge, but once decentralization has started, we encourage the district hospitals and things to try and then procure 1 or 2 neonatal jaundice equipment, either phototherapy units, a very good one, and then some logistics. And then the transport system, that one, it's a bit above us, but we can advocate for a better transport system, especially pediatric transport system, where we can get incubators and even as we said, billy beds, and even for respiratory support so that these babies can be transported to higher facilities when the need arises. Referral system, decentralized. We have decentralized care, so there are short movements from one area to the other. Zonal concept system initiative is very important. When you're able to clone the zones, then you know that you are okay. The only thing is to be able to do interzonal referrals through WhatsApp groups so that we know where each case is going to. Leadership interest in neonatal jaundice is another. Neonatal jaundice, because it comes with equipment and logistics, leadership sometimes are not too interested in it. But when we do, it will help, because if you check the OPD attendance rate, you see that when it comes to the neonatal period, a lot of neonatal jaundice comes. So 6 out of 10 babies can be jaundice. 8 out of 10 babies can be jaundice when they are preterm. So there's a lot to really make out of them when you put in measures where you can accept them and manage them. I think you also make profits out of that. Antenatal care services, importance of pregnancy school concept is very, very important. With the COVID-19, most of the services collapsed, but then the antenatal care services were building up. They were doing very well. As stillbirth rates dropped, because there's been a lot of teaching when it comes to the pregnancy school concept, where they are taught about neonatal jaundice, what to expect and everything. So when they come out and they see them, they're able to work on it. So we should encourage that these already existing practices should be put to play to better help the system. So in conclusion, improving neonatal care in Ghana requires an integrated strategy involving all trained health workers and adequately resourced health system, supportive policies, and an informed public. So, they say if you educate a woman, you educate the nation. So we should do our very best to make sure our women are educated when it comes to neonatal jaundice. So collaboration among these groups significantly contributed to the reduction of what we are seeing today. Although it's not as we want, but there has been a step towards a good move. So jaundice-related morbidity and mortality. So now we are getting a lot of morbidity, but the mortality rate is declining. Thank you. So these are some of the references. This acknowledgement goes to these people, and end of presentation.
Lovely. Thank you so much, Dr. Bracco, for that awesome presentation, for just reminding us and telling us the strategies that are available to improve care across Ghana. Each and every one of us on this platform, I believe, has a role to play, from the healthcare provider, the healthcare system itself, the various stakeholders, and the general public. Thank you so much. So we put up the links for the evaluation of this program and also the link for the CPD points. So please, let's do well to fill that. We'll give just 3 minutes to go through the questions that were put up on YouTube. Unfortunately, because of time, we can't do everything. So I'll just read through the questions quickly, and if our presenters can help us with the answers. So the first question is, good evening. Please, I would like to know the importance of gravidity and parity in diagnosing neonatal jaundice. The importance of gravidity and parity. Dr. Rekubrebe, I think if you are on, this will be yours.
I think the only time that it becomes relevant is when you're worried about Well, can you hear me, Nanama?
Yes, please, loud and
Okay.
clear.
When you're worried about immune-mediated hemolysis, so suppose the mother is of blood type O, and the baby daddy is let's say A or B. So that means there's a 50% chance that the baby will take that of the father. So if the baby is A, that means the antibodies will be formed against the baby's blood type, right? And with each pregnancy, the amount of antibodies goes up. Okay, so that means that the severity of the hemolysis also go up with each subsequent pregnancy. Only if the fetus or the baby takes after the father's blood group. So that is
Right.
when the gravidity comes in. With the so if you have I had this mother who had she had about, is it 4 girls, and 4 boys, and she wanted a girl. She was O positive, the husband was B positive, and some way somehow all the kids had taken their father's blood type. So the first baby wasn't even that jaundice. Maybe around day 5 there was this hint of jaundice. Didn't even require phototherapy. We did the SBR, was fine. Then the second baby, like 4 days old, became jaundiced, needed phototherapy. Third baby, 2.5 days old, became jaundiced, needed phototherapy. Fourth baby, I think by 20 hours old, was jaundiced, required an exchange blood transfusion. But this woman still wanted a girl. So she gets pregnant again. She was advised that as soon as she delivers, she would usually go and deliver in a private facility. She should bring the baby. But she didn't listen. By evening, she delivered around 6 a.m. By evening, the baby was jaundiced from head to toe. The baby required 2 blood exchanges. So you see that with each subsequent pregnancies, the number of the amount of, or the volume of the maternal antibodies will increase in number, and then that would reflect in the severity of the hemolysis. And the same goes for rhesus incompatibility. Yeah.
All right. Thank you very much for that. I think the last one we'll take will be, she says, over the years, I've noticed that most CS babies end up at the NICU with jaundice, mostly due to breastfeeding issues. Please, how can we help prevent this?
So it's got to do with how early the mothers come down to breastfeed. I'm not sure how it works in other facilities, but if I use Cath as an example, we have the mothers on the postnatal ward in another block, and then the MBU is also a distance away. And most times, at least I think in the last couple of years or so, the reporting time to the MBU post CS has gone down. Initially, it was around 72 hours on the average. Now, I think is roughly maybe 40, 48 hours. That is how soon they come to breastfeed. So it's also got to do with pain management, the mother's threshold for handling pain and all that, because at the end of the day, it's how soon she comes down. If I were to say something, if I were to suggest something, which would be totally the B on my part, that would also mean that, I mean, maybe in the future, if we should encourage rooming in. So if our facilities are such that we do not separate mothers and babies. So she has a CS, she goes to her room, and then the baby is lying by her side. And then even if the baby is not well, let's say the baby has TTN, everything can be managed by the mother's bedside as well. So basically the mother NICU concept, that would eliminate all of that. But I
Awesome.
suppose, yes, time will tell.
Time will certainly tell. Thank you so much. So at this point, I'll call in the chairperson for the occasion. Prof, please give us your final words and then we'll pray.
Thank you very much. Could you have had a better lunch or late lunch than what we've just had here? And I think for me, it's been a very, very great session. We say a big thank you to all the presenters who presented and for the education that we've been provided. Whilst we were talking, I was talking to a colleague on the side who told me about a TikTok a video about a lady whose child had jaundice, and she put the child on TikTok and asked people in the public to tell her what to do. Some said they should grind this and smear on the baby's nose. Some said they should put something into the baby's ears. At the end of the day, she then realized that the baby was getting worse, and then she said she was going to the hospital. These are the spaces that normally people who are on this platform do not patronize that much. But I think that social media is also a great opportunity for us to be able to reach out to many more people. And I think that if you have never been on social media this yellow month, please take the opportunity to go on social media and let us know more about neonatal jaundice. I thank you all, and it's been a great pleasure. Let's go and spread the news. We can save lives. Thank you.
Thank you very much, Prof. On that occasion, Prof is sending all of us to go out there and be social media advocates. You and I all use social media, so there's no reason not to do it. Post it on your status, share something on Instagram, on Twitter, anywhere you find yourself. Please, let's all be advocates. So on that note, I'll call Dr. Mednana Kwesi Ababio to say the closing prayer for us, and we'll be done. I'd also like to remind us that t-shirts are ongoing. They're being sold for Greater Accra region. You can contact Dr. Aglobiche for the various prices and the sale points. So please do that. Let's grab a t-shirt so that you can go out there and brighten the corner where you are. Dr. Ababio, please do us the honors of the closing prayer. Unless we lost Dr. Ababio.
No, I'm here. Hello.
All right, great. I can hear you.
All right. Good evening, everyone. A big thank you to all our presenters. It's been insightful. God bless you all for such a wonderful presentation. Shall we pray? Father, in the mighty name of Jesus, we are eternally grateful to you for this evening. We come before you with hearts full of gratitude for the success of today's launch of one of our annual flagship programs for the Pediatric Society of Ghana, the Neonatal Jaundice Awareness Month. We thank you for guiding us through this gathering, for the knowledge shared, and equipping members for the advocacy ahead. Even as we embark on this awareness this month and beyond, may this bring about improved outcomes, timely interventions, and overall prevention of neonatal jaundice complications and brighter futures for our newborns. As we go our separate ways, Father, may your presence go with us. Fill our hearts with renewed commitment to the health and well-being of every child entrusted to our care. Let our hands continue to be a healing balm for all these children that you place under our care. Take glory, Father. Take glory, Son. Take glory, Holy Spirit. In Jesus' name, amen.
Amen. Thank you so much. God bless you all. Have a lovely weekend and go out there and spread the yellow all around. Bye-bye.